So welcome back to the fifth part of this antimicrobial in ICU. I know it's becoming lengthier day by day, but I am going into details of each individual topic. The reason behind, I am also getting good feedback from the student because there are a lot many students who cannot understand this concept in a one go, right? So again, I repeat, this is not a lecture, but a small attempt to make you understand these difficult topics. But it's your duty to read in more in details and to apply them at your bedside. So let's not waste the time with this top words. And now coming to our core topic, we were left into susceptibility, resistance, and the intermediate category, which we ended in the last portion of the video. So now we will be coming into the PK/PD indices, right? So we will be learning this term. So before going into the PK/PD indices, we have already learned PK or the pharmacokinetics and the pharmacodynamics of the drug, right? So in the pharmacokinetics, we have learned absorption, distribution, metabolism, and elimination. By this, the drug achieves a concentration along the course of time and gradually decline over the course of time. In the pharmacodynamics, we have learned that dynamics in the D is the what drug does to the body, right? So what drugs does to the body, it binds to the receptor, it produces an effect, and we measure the effect according to the concentration, right? By which we measure terms or parameters like potency or the action of the drug, right? So combining these two together, we can come to a term which is PK and PD both. And its measure basically not only the concentration over the time, not only the effect against the concentration, combining two, merging up is the effect against the time, right? So it is basically the effect against the time which we will be studying in the PK/PD. So let's not waste the time in this slide. So the concept is combining these two together and to study the effect of the drug in respect to the time. So we will be talking in details. Whosoever not understand the concept now will gradually understand as we go on discussing. So these PK/PD indices are very, very famous terms. T greater than MIC, Cmax by MIC, AUC by MIC, and MIC, if you ask me again, I will not reply because we have already learned in details what is called MIC or MBC. So coming to these terms, we will be reading and learning in the subsequent slide. Don't get panic with this term in this slide. We will be reading in the subsequent slide. So coming to the PK/PD indices of the drug, classifying by the PK/PD drug by the PK/PD indices, the drug is basically divided into three parts or three categories: time dependent, concentration dependent, and another is concentration dependent with time dependent. We will be clarifying this more in the further slides. This part is only focused on these categories of drug. So what is time dependent? So the name only suggests that these drugs are dependent on time. That means these drugs takes time to act. If you go to a school or a college, if you imagine your class during your college, there are three categories of student. One, who takes time to study. उतना जल्दी नहीं हो पाते उनसे, दो पत्ता पढ़ने के लिए भी उनको टाइम लगता है, and that's good. They are also studious. There is a certain section of student who just sit 2 days before the exam and finish up those 2 pages. They are also studious and intelligent. And there is another category of student who used to read throughout the year with time and used to revise with a high concentration before the exam. So The first category of student who needs time to study is a time dependent. Second category of the student who never studies anything, only studies before the exam with a full concentration, with all the doors shut, with a peak concentration, is concentration dependent, and who studies throughout the year with time and again revise before the exam with high concentration is basically the concentration dependent with time dependent. So they need both. They need time to study and they need concentration to revise before the exam with a peak concentration. So you see, it's very clear. MIC के ऊपर तो जाना ही है. So every story goes above MIC. There are little story below MIC, which is known as post-antibiotic effect. We will be discussing in the subsequent slide. But now what we will discuss, the story begins above MIC. So trace this curve. This is a concentration curve. Concentration उठ रहा है. Once it goes above MIC, starts going above MIC, the action of the drug starts. It reaches a peak concentration and then again fall and reaches. This doesn't touch the baseline. If in this graph it is touching, it is supposed not to touch the baseline. So it reaches a minimum concentration. So any concentration below this dotted line MIC, this upstroke and this downstroke has no meaning. The story happens only above this MIC. Be it in time dependent, be it concentration dependent. मतलब ये चीज है, पढ़ना तो है, बुक खोलना है. Without opening book, you cannot be a studious guide. So the opening the book is the minimum requirement before the exam. So what do I discuss? The category of students. So the minimum requirement is MIC. So har kahani is starting above MIC. So there is no story below MIC. Now, some antibiotic action depend on how much time it spends above the MIC. So in the full timeline, this portion of the black bracketed portion is only the time which the drug spends above MIC. So this is basically percentage of time during which the drug was above MIC. This is the meaning of percentage T greater than MIC. Means kiska percentage? The percentage of the whole duration the drug was measured, right? Actually what is happening, we are giving meropenem TDS. So first meropenem दिया, peak concentration achieve हुआ, फिर आ गया एक minimum level पे, फिर ये खत्म होते, ये 8 घंटे की स्पैन था, खत्म होते we give a second, so we give another peak. So this is a peak for a single dosing. So ये जो 8 घंटे की स्पैन था, जिसके बाद हम दोबारा सेकेंड डोज को दे रहे, उस स्पैन का कितना परसेंटेज ऑफ टाइम? सो इट इज बेसिकली द परसेंटेज ऑफ द ड्रग ड्यूरेशन और द ड्रग फ्रीक्वेंसी during which the drug is above the MIC, right? So if we are giving 8 hourly meropenem and we say ki 50% time the drug was above MIC, that means for 4 hours the meropenem was above MIC, right? So this is what the time dependent drug matters. So we will be coming kisko kitna percent chahiye, who all are this time dependent, right? So clear the concept. The time dependent means how much the drug was above MIC, how much time the drug was above MIC in percentage of the duration of the drug frequency or the frequency at which the drug is given. अगर 8 घंटे के ड्रग फ्रीक्वेंसी पे दे रहे हैं हम, TDS दे रहे हैं, so if we say 50% time it was above MIC, means 4 hours it was above MIC. We will be coming to the subsequent example. You will understand more and more. No need to panic. Now, if it's concentration, so this is MIC. इस कैटेगरी का ड्रग का क्या मतलब है? दैट MIC का ऊपर तो जाना ही है, कहानी तो MIC के नीचे कुछ नहीं बन रहा है. So you have to go above MIC. So the story here is, it depends how much times the drug goes above MIC. इसका कोई मतलब नहीं है कि हम 4 घंटे रहे, 5 घंटे रहे, but the concentration of the drug should be 10 times above MIC. This drug generally needs 10 times concentration above MIC. बुक खोल के बैठे रहे कोई मतलब नहीं है इन स्टूडेंट्स में. They needs the peak concentration to study and to finish off the whole story within few hours, right? They don't need time. They need peak concentration. So just like those students, this drug needs a peak concentration, and these drugs are called concentration dependent MIC. So they are measured Cmax because you need the peak concentration. The peak concentration is known as Cmax, or concentration maximum, divided by MIC. It should be at least 10 times, 8 to 10 times. So this drug needs a high concentration. So coming to the third category, what happened? Some needs time. So the x-axis is time. Some needs concentration. Why? Now, if a drug needs both, then X into Y becomes the area. This is very simple. There is nothing new or new logic to understand. So the area under the curve, this, remember, this actually the term is area under the inhibitory curve, means the area under the curve above the MIC, because no story is built below the MIC. There are some story we will be discussing later. Those are post-antibiotic effect. But now all the stories are cooking above the MIC. So the area of the curve above the MIC divided by MIC gives you the PKPD parameters of this third category of the drug. So it's very clear. T percentage greater than MIC for time dependent, Cmax divided by MIC for concentration dependent, AUC by MIC for concentration dependent with time dependent. We will be coming to the classification, which drug belongs to which category in the subsequent slide. The first drug is the time dependent antibiotic. We have already discussed what T percentage MIC means. The percentage of time between the consecutive administration of an antibiotic in which the drug concentration remain above the MIC. The closer the T MIC to 100%, ये तो सब चाहते हैं कि हम पूरे टाइम पढ़े, but there are so many distractions we cannot read. So T greater than MIC parameter बहुत अच्छा होता अगर 100% होते, पूरे टाइम वो MIC के ऊपर रहे. वो तो मैं भी चाहता हूँ बहुत कुछ करना, but the thing is not, those are not realistic. So T greater than MIC, 100% is not a realistic scenario, but more it becomes, the better is its outcome. So coming to the specific drug, MIC is inhibitory, right? So it's becomes static, but we want to kill the drug. So you have to remember, for penicillin, it is 50%, means if you are giving penicillin TDS 8 घंटे का, so the drug should remain above MIC for 4 hours. For cephalosporin, you have to remember this percentage because you want to kill. So near maximal bactericidal effect, right? For cephalosporin, it is 60%. For carbapenem, it is 40. So I remember like this: carbapenem 40, penicillin 50, and cephalosporin 60. So 1C in one end, 1C in another end. 1C minimum 40, another C cephalosporin 60, and in between sandwich is the P or penicillin, that is 50. So 40, 50, 60. These are the T percentage. Means agar dono drug you are giving BD, right? Suppose you are giving any drug BD, like ceftriaxone BD. So for cephalosporin, these 12 hours, so the drug should remain above MIC for 7 hours, right? So the drug should remain above MIC for 7 hours. So this is the concept, that T percentage greater than MIC. So one thing is very clear. Let me make you understand. From this graph, you will be, we are going one step ahead in the concept. We have learned T percentage MIC. So if an organism, suppose Klebsiella, is having an X MIC for meropenem, which is this, right? MIC for meropenem above 2 is resistant. So MIC 1, suppose not meropenem, suppose taken drug for which the Klebsiella is showing an MIC 1, right? So if we give a drug, there is sufficient amount of time, as the MIC is very low, there is sufficient amount of time above the MIC. We don't need to think that whether the drug will be above MIC or not. But if as higher we go, if we make the MIC to be 4, then you see the graph above the MIC become very short. So either we need to raise the peak more, or we need to make the down slope more sloping. So how can we make the peak more? We can increase the dose of the drug. So we can go 1 gram meropenem from 2 gram meropenem. How can we make the down slope more sloping? By giving the drug through a continuous infusion, right? So the concept built from here is why we need to give a drug through continuous infusion, right? So see, again I am explaining. If the MIC is low and the MIC is 1, there is sufficient amount of graph which is above the MIC. This whole portion is above the MIC, right? So we don't need to think that there is a huge time. We are giving 8 hourly, so the graph is about 8 hours. So below, above MIC, you see, if the MIC would have been 1, there is a huge time the drug spending above MIC. When the MIC climb up to 4, there is a very small time in this graph. If we give the drug like this, there is a very small time of the drug above the MIC. So this portion is only above MIC. And if the whole portion we take T, then it will be around 30 to 40%, right? So if we need to have this much amount of drug above MIC, then we need to create the graph with a more higher peak and a slower downfall, right? Or downward slope. So to make a high peak, we need to increase the dose to have a gradual down slope. What we need to make it a continuous infusion, right? So there comes the role. If the drug are having an higher MIC, and which is very common in India, you need a continuous infusion. Today, if you go back and see the IDSA guideline, you will see that the meropenem is to be given over 30 minutes. And you may come and ask, sir or my dear senior, you taught me the meropenem to be given over 3 hours, and IDSA people are saying to give it over 30 minutes. So do you have a extra knowledge over IDSA, people? The answer is no, because I am working in an Indian scenario and the IDSA guideline is written in an American scenario. In an American scenario, the MIC of the drugs for a certain bugs are very low. So if they also give over 30 minutes a bolus of meropenem, they will get a sufficient time above MIC because their MIC are pretty low. And we are working in these zones where MICs are very high. So if we give a bolus, the same graph will be formed and we will get a very small time above MIC and our PKPD will not be achieved. So for the resistant bug or for the high MIC bug, you need to increase the dose or you need to give a continuous infusion. That is why still now the continuous infusion studies which are done in the Western countries haven't given us a very good benefit. Rather, it would have given, it would have done in an Indian scenario, right? So the continuous infusion is a very good option for in our scenario. So you can say, sir, do you call this 3 hours as a continuous infusion? It is basically an intermediate. There are 3 types of antibiotic administration. One is bolus administration, what IDS speaks about, over 30 minutes. There is an intermittent infusion, which we give generally over 3 hours. And what is continuous infusion, that is over 24 hours. So if you are giving 1 gram TDS meropenem, then actually it should be given 3 gram over 24 hours. But don't mix 3 gram together because the drug has a certain shelf life, right? So we need to consider everything. So the topic is not very small. आज कुछ सीख लिया तो कल जाके bedside में we start applying. So the drug has a shelf life. You cannot mix 3 gram together. But what is clear from this slide, that bolus administration is better. Continuous or intermittent infusions are better than the bolus administration in our Indian scenario because we are having bugs in higher MICs, right? Now coming to this diagram, this will make your concept more clearer. I have tried to copy paste pictures so that you make your concept more clearer. Now see, there is an ICU and you people are working and you are giving a drug 1 gram TDS meropenem or a 1 gram TDS beta-lactam, right? Let's take meropenem or any piperacillin tazobactam. So you were giving meropenem at 1 gram TDS. Now see, this is the black, not the dotted one, the solid black line. And you see the MIC is around 10 hai, so 16 almost, right? So this is the MIC. So you see very small amount, very small, this much is the time above MIC. Now you do this drug 1 gram to 2 gram. What I taught you, that the concentration will be high and the downslope will gradually be more sloper and you get an extra age of 25% of the time above MIC, right? Now you can combat these drug up to MIC, these bugs up to MIC 16. Coming to the next, you see, again 1 gram. Now you have here you have increased the dose, right? Now coming to this, now you have increased the frequency, right? So 1 gram TDS. So this solid line is 1 gram TDS. You are giving 1 gram QID. So 1 gram diya to concentration remains the same, right? Because we both are giving in 30 minutes. This is bolus administration. We are not talking about infusion till now. All are bolus administration. So the peak concentration remain the same. But what we cut down is the dose interval, right? So where the next dose was supposed to be start from 8 hour and my T, so jiska percentage we were calculating were this much, now have cut down to 6 hour and now the T is this much. Now this portion which is above MIC was almost 50% of that 8 hour. It was 4 hour only. Now when we have done 6 hours, this T greater than MIC has become 80%, almost 70 to 80%, right? So we are increasing T percentage greater than MIC by increasing the dose, by increasing the frequency. इसलिए ना हम बोलते हैं कि टैजेक को TDS मत दो, QID दो. Why? 4.5 ग्राम TDS लिख के चले जाते हैं कोई, हम तो हर में काटते हैं. ठीक है, for pseudomonas I agree, but there are pharmacokinetics and dynamics also. So it's better if you increase the dose, if you increase the frequency to cover up for the higher MIC bugs. Now coming, this is bolus and this is continuous infusion comparison. So you give a bolus, meropenem ko stat de diya. So the time you spend above MIC, this line, this is MIC. So the time you spend above MIC was 4 hours. When you give a infusion, you increases 25% of the time and you now spend 5 hours almost above MIC. So if the duration was 8 hours and you were spending 4 hours above MIC, then it was 50%. Now you have come up to almost 60% above the MIC. So you see that if you are increasing, so this is the reason why it is very necessary to give infusion for these drugs. तो कोई बोलते हैं कि मेरे को नहीं तो देना है 30 minutes में दे दो. No यार, there is certain reason why it has been formulated to be given over 3 hours, right? This graph will make your concept crystal clear. Even if you don't understand, comment down below for the videos. I will share my contact number with you and you can have a one-to-one interaction. There is no necessary of paying anything, subscribing any course, because these are the core concept which all juniors should be cleared irrespective of whatever exam they are giving, right? Now, see the beauty. If you are increasing the dose also and you are giving my infusion, you are 25 plus 25, you are increasing the time above. Now the graph becomes this because you are increasing the concentration, but you are giving infusion. So it is not rising as much. It has risen in the first graph, but it is almost rising up to the bolus administration of 1 gram. And it is coming down slowly. So there is an increase of 50% above the MIC. So the percentage of time above the MIC is increased almost up to 50%. If we increase the drug and we give it in infusion, this is the reason I have also explained during explaining breakpoint that we increase the dose of meropenem from 1 gram of TDS to 2 gram TDS when meropenem is resistant, and we try to cover up to an MIC 16. So by doing all this, you cannot go above 2 gram TDS, right? I have explained you cannot go 10 gram TDS and killing the liver and kidney and making the patient microbial free. So that's not the good thing to do. But you can go up to 2 gram TDS. By going 2 gram TDS, you can catch up with the bug of meropenem with an MIC 8 to 16. So above 2 is resistant. So if you are getting meropenem resistant, look into the MICs. If the MIC is up to 16 maximum, some says 8, some says 16, okay, then you can cover those bugs with a higher dose of meropenem, that is 2 gram, and by an infusion keeping in mind the organ failures, you don't give 2 gram TDS in a kidney disease or a AKI patient, severe AKI patients. But unfortunately, these scenarios are very common when you are treating a critically ill patient. AKI is very common. But you need to keep in mind, you can increase the dose and can catch up with those carbapenem resistant organism. It is why you sometimes see that the seniors, faculties, and your teachers are using meropenams, even if the patient is meropenem resistant, but you need to use judiciously. If you are using 1 gram TDS bolus in a carbapenem resistance organism, then you are giving an MVI in the name of meropenem, right? So that's not the right thing. You need to increase the dose. You need to give through infusion. You cannot come down with the frequency, come up with the frequency, but you can do so in case of Tazac or piperacillin tazobactam. So remember these things. These are the beauty between a trained qualified intensivist and somebody going and doing a locum and counting the money in the ICU, right? So these things, these finer, minute things makes the difference between you and that guy. So coming, see, it is piperacillin tazobactam. What I have said, I have, this is a beautiful slide from the Stanford video, which is available in the YouTube also, that, see, there are 3 graphs, basically. The blue is if the Tazac is given 3 gram IV 6 hourly, 3.375 gram over 30 minutes. This red graph is 4.5 gram given 6 hourly over a 30-minute bolus. And the beauty of this green graph, where it is 4.5 gram 6 hourly given over 4 hours time, right? So our main goal is to attain this PKPD or the killing of bacteria in 90% of the patient. So the goal is 90%. So the red line is the 90% target attainment. So we can attain with 3.375 IVQ 6 hourly or QID given bolus in by this mechanism, we can attain if the bug is having a MIC up to 8. When we increase the dose 4.5 gram, then also it is killing up to 8, almost. You see, 90%. Where it is intersecting with the 90% line, it is 8. But the beauty you see, once you do it an infusion and 4 hours infusion, 4.5 gram IV 6 hourly, the same thing. This red line and green line, those remain the same. But you become a qualified to from an unqualified to a qualified intensivist, and you just change a minute sister isco infusion pedal though 4 hours. You have a coverage up to an MIC 32. So more the coverage, more the bug will be cleared, and there will be less chance of therapeutic failure, right? So this is the reason why we go for extended infusion. Same in case of cefepime. You see, these are the different drug doses. But when you have a 2 gram TDS, cefepime can be given 1 gram QID to 2 gram QID, right? So when you do a 2 gram TDS dosing, you see the percentage of killing, though it is given in 30 minutes infusion, as because these are the Western studies. So 95.8, 95.8. So this is a maximum killing when you are increasing the dose and you are increasing the frequency from 12 to 6. So you increase 2 gram BD to 2 gram TDS. You see that percentage change from 78.9 to 95.8. So the bottom line of the story, to kill the bacteria with higher MIC, number 1, increase the dose if permit physiologically, increase the frequency if permit physiologically, give the drug through a continuous infusion or intermittent infusion. ये तो physiologically permit करेगा, but take in consider the shelf life of the drug. So this part is very clear. You can see along with the meropenem. See, the meropenem, what we normally give is 1 gram TDS. This black dot wala, ठीक है, goal wala. You just zoom in and see this goal wala, circle wala line. So this is the circle wala line. And if you see the 90%, we need a 90% attainment, right? So this is coming to somewhat MIC 2 and 4. So if we give an intermittent bolus 1 gram QID, 1 gram TDS, so you can cover maximum MIC up to 2 and 4. Now coming to this shape where it is extended infusion of 1 gram TDS, right? So if you give a 1 gram TDS, then also you can attend between 4 to 8. So if you make a continuous infusion of 3 gram over 24 hours, see, this is the square box, you get to cover around up to 16 MIC, right? Now, if you come down here, you give 2 gram TDS. Now, this is the circle. So in 2 gram TDS, if you are giving bolus, then also you are covering up between 4 to 8. But if you give an extended infusion that is over 3 hours, you are covering around of between 8 to 16. So you see this 90% attainment, draw a straight line from 90%. We need to attend these PKPDs in 90% of the patients. Okay, so these are done in laboratories. So you see, if the MIC is 4 to 8, you can attend with a bolus 2 mg TDS. And when you make an infusion, this dot shift here and it comes between 8 to 16. And if you make it a 6 gram per day continuous infusion, pura din chalega, what we use in our ICUs, right, is you shift this MIC of this square from 16 to, so you are almost covering a bug with an MIC 16, which is normally written resistant, because above 2 meropenem will be resistant. So it is written resistant. But if you are giving 2 gram TDS, that is 6 gram over 24 hours, you can cover up the bug up to the MIC 32, right? So these are the reason why we say that this time dependent antibiotic को थोड़ा time से time लेके देना है, right? So these are the gentle tenders antibiotic which needs to be cared with time and over time. सिस्टर तो खुश हो गई, 30 मिनट्स में दे दे, राइट, कम खत्म, 5 मिनट में बोलस दे दे. आई हैव सीन गिविंग बोलसेस. ओके, सो दैट डजंट, बोलस देने से तो अच्छा है एक रेंटेक दे दो, राइट? सो वो अगर सही हो रहा है, वो बॉडी का फिजियोलॉजी है जो उसको सही कर रहा है. दैट्स नॉट द ड्रग, दैट इज द बॉडीज फिजियोलॉजी एंड इम्यूनिटी विच इज फाइटिंग and making the patient better. So solution in time dependent antibiotic: double the dose, shortening the dosing interval, prolonging the infusion time, and combination of increasing the dose and prolonged infusion, if can be done, is the best option. So we will be coming to this trial, Mercy and the Blink 3 trial, in the subsequent discussion.